So same thing with motor testing. Obviously we have some normal values. Just be aware of the different nerves that we can test, and obviously be aware of what muscles those nerves innervate. A lot of words on this slide, a lot of new terms. Okay, there's a couple different nomenclature strategies. There's a couple different stratifications, if you will. The easy one is neuropraxia, axonometesis, and neurometesis. Neurotemesis and axonotemesis. Just be aware of these. Be aware that sometimes you're going to see the Seddon nomenclature strategy. Sometimes you'll see the Sunderland nomenclature strategy. Now, looking at the classification of nerve pathology, be aware of what we're looking at here. Okay, so neuropraxia, look what's happening. We have a reduction in myelin. Okay, we have a block, demyelination, and there's a conduction block because there's no myelin in that section. Axonotemesis, we're looking at actual axonal loss. Now, looking at neurotemesis with a grade 3, okay, this is obviously more severe because now what's happened is that we have a total disruption in myelin and a total disruption in the axon. Moving forward to grade 4 and grade 5, we see a very similar distribution where we actually still have a total loss in myelin, total loss in axon, but obviously those outer layers are starting to become disrupted as well. So as we move farther and farther out and the neuron is actually being disrupted, we obviously have more damage and therefore more findings. Alright, some more definitions here. Neuropraxia, interruption in conduction. The nerve elements, however, are normal. So basically we have some abnormal findings, but the nerve is normal. Usually the patient will come back with a full recovery, but it takes around 6 to 8 weeks. Axonotemesis, what we're looking at here is loss in axon continuity. EMG, usually 2 to 3 weeks later after the injury, is going to show denervation. And fibrillation, remember that's going to be that instability in potentials. The epineurium is preserved. The axon may regenerate at a rate of about 1 millimeter per day, which is normal. And usually there's going to be an incomplete recovery. So this is going to be a person that does not fully recover once we get down to this axonotemesis stage. So now neurotemesis, complete loss of nerve function. What we're looking at is going to include loss or scarring of all the neural elements, and they can still do surgery that's going to help with pain, but we're not going to expect to get anything else back after that. So take a look at these upcoming slides, and what we're going to see is how the different waveforms correlate to the different pathologies. So when we look at an axonal loss, this is going to be the most common pattern seen, most common pathology seen on nerve conduction study. The axons are lost, so the amplitude decreases. Remember, decreasing amplitude means axonal loss. We're going to have a reduced amplitude in our CMAPs and our SNAPs. So what we're going to do is we're going to compare that with a normal value, also compare with previous baseline values if we have those available, or push comes to shove, we're going to use the contralateral asymptomatic side as a comparison. So looking at axonal loss even farther, when the amplitude markedly decreases, the conduction velocity and distal latency are going to remain normal due to the preservation of the fastest fibers. So when that amplitude goes down, we're still going to have some fibers in the middle that are going to give us that conduction velocity. So what I want you to kind of get out of this is those fastest fibers those most important fibers, those are the ones in the middle. We're going to lose the least important ones first, but then that's going to show a decrease in amplitude. Okay, so how much axonal loss is too much axonal loss? So when we're looking at normal versus abnormal, obviously the amplitude is going to decrease. We're going to have a very flat line, or a flatter line. So below 75% of normal is abnormal. Distal latencies are normal or slightly prolonged, but never greater than 130% of the upper limit of normal. So in other words, above 130% is abnormal. Below 75% is abnormal. And like everything else, there's exceptions. So the only exception occurs in hyperacute axonal loss lesions. So basically a nerve transection. I cut my nerve in half. Day 3 to day 4 of that happening, you could still have a normal nerve conduction study. However, get down to day 3 to day 10 and Wallerian degeneration occurs. So it's going to start going through this degeneration process. That's going to result in changes that we can see with low amplitude distally and proximally. So the process of Wallerian degeneration, for motor fibers, typically 3 to 5 days we're going to see it. Sensory fibers take a little longer. They're going to be about 6 to 10. And then at that point, you're going to see these changes happen on nerve conduction studies. So in terms of demyelination, myelin is essential for saltatory conduction. We have to have myelin. Without myelin, nothing's getting through. It's the insulation around the nerve. It is essential for nerve conduction. So what we're looking at and how we can determine if demyelination has happened is slowing of conduction velocity, prolonged distal latency, and conduction velocities and latencies slower than the normal cutoff values imply that we have demyelination happening. So any motor or sensory nerve conduction velocity that is slower than 35 millimeters per millisecond in the arms or 30 millimeters per millisecond in the legs signifies unequivocal demyelination. So regenerating nerve fibers after complete axonal injury, so for example, I cut my nerve in half, can be this slow and not signify a demyelinating nerve, or a demyelinating lesion, I should say. So when we look at demyelination, there's a borderline slowing, and that refers to the amplitude of the potential. If it's normal amplitude, we probably are dealing with the demyelinated nerve. If there's a serious issue with the amplitude, then we're looking at severe axonal loss. And take a look at the slide in the picture inside the slide, and it'll give you a good idea of that. So amplitude changes are going to be variable when we're speaking about demyelination. Reduced amplitudes not necessarily a marker of axonal loss, and that's going to depend on a couple of conditions. Sensory amplitudes are often low in demyelinating lesions. So that's a result from temporal dispersion and phase cancellation, which are normal, but is exaggerated by demyelinative nerve slowing, which then lowers sensory amplitudes. So take a look at this slide. Basically what this is showing is a conduction block. Okay, so it's looking at reduced amplitudes in demyelinating lesions. Those are going to be present when a conduction block exists. So look at A, look at B, look at C, look at the top down. The top's obviously giving you a normal. And then conduction failure is going to be the very bottom one. So looking at normal versus conduction block here. Obviously what we're looking at is on the left hand side of the screen, these are normal potentials. This is normally what we should see. There's a big change versus the abnormal. So what we're looking at in the top is we still have a normal potential because we still have nerve fiber, we still have nerve conduction happening. The bottom, we have a serious waveform problem. So just be able to identify that, be able to identify the fact that we can have some nerve blocks happen and still have a normal potential. Obviously go back a few slides for those certain situations. So this is taking a little closer look at conduction blocks. So if a conduction block is present in a demyelinating lesion, CMAP amplitude depends on the site of the stimulation and the location of the conduction block. So definitely take a look at where the conduction block occurs. Now, obviously, and this one makes a lot of sense, if our stimulating electrode and our reference electrode are not in the area of the lesion, we will see a normal potential happen. So from studies in normal subjects, CMAP, amplitude, and area don't usually decrease by more than about 20%. CMAP duration generally does not increase by more than 15% when recorded from typical distal and proximal stimulation sites. Demyelinating lesions, temporal dispersion, and phase cancellation become more prominent for motor fibers. So just be aware of that we're going to see more marked changes in motor fibers than we do sensory fibers. When we're talking about conduction block, basically what we're talking about here is more than a 50% drop in the area between the proximal and distal stimulation sites. So just be aware of that when someone has a conduction block or you read that in a report, that's exactly what it means, is that we have a more than 50% drop. So when looking at axonal loss, what I want you to look at is obviously the area that's highlighted in yellow. Understand that Eulerian degeneration of the nerve does not occur until about 3 to 5 days for motor fibers and 6 to 10 days for sensory fibers. And then just be aware of how that presents on an EMG, and how it presents on NCV, and how that process occurs. So looking at axonal loss and time-related changes, just be aware of how that curve acts. Obviously what we're just looking at here is the difference between a CMAP and a SNAP. Obviously we can see that the CMAP loses amplitude and loses power and juice a lot quicker than a SNAP or a sensory fiber does. Thank you guys very much for your time and attention during this slideshow presentation and the EMG slides. And I wish you best of luck on the final exam for this course, and it's been very nice working with everybody. I hope to see everyone next semester, and we'll have some fun next semester.